Dr. Sovik, can you hear me? Dr. Sovik, we are
Yes,
live now. You can start the show. Thank you.
thank you. Good evening and welcome to the expert crosstalk on Empagliflozin, multi-pronged, multifaceted and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, cardiology and endocrinology, which would bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to a ratio trial, does SGLT2 inhibitor can be considered as an important drug for heart failure? And for this, let me introduce today's speakers. Today's speakers are Dr. Ashok Punjabi and Dr. Rajiv Kovil, and I am your moderator, Dr. Shavik. Dr. Kovil is a director and consultant diabetologist at Dr. Kovil's Diabetes Care Center and Preventive Diabetes Center and Diabetic Foot Clinic at Nanavati Super Specialty Hospital and also several other prestigious hospitals in Mumbai. He's also a founder member of United Diabetes Forum and also received several prestigious awards till date. He's also faculty and speaker in various symposiums and has several national and international publications in his credit and also a principal and co-investigator in various trials. I welcome Dr. Kovil in this expert web talk.
Thank you so much, Dr. Chaudhary.
Welcome, sir. Our next speaker is Dr. Ashok Punjabi. Dr. Ashok is a medical director, Krishna Cardiac Care Center, Mumbai. He's a consultant cardiologist at Lilavati Hospital and Research Center at Global Hospitals in Mumbai. And he is also a regular teacher for nursing courses and also has several national and international publications in his credit and also has participated in a number of national and international symposium. He is also part of many registry and service carried out at Krishna Cardiac Care Center. I welcome Dr. Ashok in this expert web talk. And I have handed over the session to Dr. Rajiv to start with his presentation. Thank you.
Thank you, Dr. Chaudhary.
Thank you, sir.
Thank you so much, Dr. Chaudhary. I think it's a unique effort basically to get two specialities which actually need to work hand in hand. And it's important that there are so many metabolic abnormalities in patients with diabetes, or I would say metabolic syndrome, which drives the global epidemic of diabetes as well as cardiovascular disease. And it's good that we have two specialists coming together and we are going to discuss empagliflozin. So in the last 1.5 decades, our approach towards treatment of diabetes has had a 360-degree change. Earlier, till 2008, we were like cowboys gunning down below an HbA1c of 6.5. And we thought that by getting an HbA1c below 6.5, we would be able to get patients reduction in mortality, reduction in morbidity and mortality related to micro and macrovascular complications. But in 2015, when the empagliflozin EMPAREX study came out in September at the EASD, it actually opened the eyes and raised a lot of eyebrows across the globe. But that we had a drug which not only reduced blood sugar, but had emergent risk reductions in heart failure and cardiovascular disease, and especially cardiovascular death. That's why we strongly believe that empagliflozin is a multi-pronged, multifaceted, and multi-benefit trial study. So in terms of SGLT2, I don't add remogliflozin to this whole calendar, but the three ones and also ertugliflozin together, they have accumulated close to 4 cardiovascular outcome trial, 2 renal outcome trial, and 2 heart failure outcome trials. So cumulatively, you have 50,000 patients in dedicated outcome trial, whether they're cardiovascular, renal, or heart failure, and we have fantastic evidence which actually strengthens the arms of everyone who's prescribing them as such. We all know how the SGLT2 works. It's important to realize that increased expression of messenger RNA in the proximal convoluted tubule is a pathophysiological defect in patients with diabetes. And by giving an SGLT2, which actually prevents the reabsorption of glucose in the proximal convoluted tubule, you're actually treating a pathophysiological defect. So close to 60 to 90 grams of glucose is passed down and is preventing from being reabsorbed at the proximal convoluted tubule, leading to urinary glucose excretion and osmotic diuresis. Now, if you look at the pharmacological properties of the available SGLT2 inhibitors, most of them are once a day preparation, and the peak plasma effect is within 1 or 2 hours. significant 60 to 80% bioavailability. Metabolism, primarily glucuronidation, there's no active metabolite. Most of them have a hepatic to renal excretion, and the glucose excretion per day lasts anywhere between 70 to 100 grams per day. If you look at empagliflozin phase 3 placebo-corrected change from baseline, it's very important to note that the HbA1c reduction is anywhere between 0.6 to 0.85, whether as monotherapy or as an addition on the background of metformin or met plus SU or even insulin. These drugs work better when an HbA1c is beyond 8.5. So you have enhanced tubular reabsorption and enhanced glomerular filtration occurring rather than at lower HbA1c as such. If you look at the placebo-corrected change from baseline in body weight, anywhere between 3 to 5 kilograms of weight loss is what we see in clinical practice. In randomized control trial, we see anywhere between 1.5 to 2 kilogram weight loss over a period of 24 to 52 weeks. If you look at the systolic blood pressure reduction, to qualify as an antihypertensive, you need at least 5 millimeter drop. Comes very close, most of the SGLT2 inhibitors, by whether it's a hemodynamic process, whether it's an osmotic diuretic process, we still don't know, but you have close to 4 to 5 millimeter drop in systolic blood pressure in all phase 3 trials. If you look at this study, which looks at a 12-week ABPM published in Diabetes Care in 2015, you can see that with empagliflozin in patients with diabetes and hypertension, you can see at the end of week 12, there is a significant 3 to 4 millimeter reduction without increase in pulse rate, because there's no compensatory tachycardia that we see with GLP-1 receptor agonists as such. Again, if you see is the diastolic, there's anywhere between 1 to 3 millimeter drop, again, without any increase in pulse rate. If you look in a wholesome way in terms of therapy, whether it's monotherapy when in patient naive, or as add-on on a background of metformin or an SU, or again and on the background of pioglitazone or a GLP-1 RA, as in the Award 9 studies, you can see that there is a tremendous reduction in HbA1c from 0.4 to 1.6, and a body weight reduction anywhere between 1.8 to 2.6 kilograms at the end of the study. If you look at these pooled analysis of adverse events, because this is one group of drugs which, as soon as it came into the market, it was bombarded with adverse events. So as soon as canagliflozin was launched, you had euglycemic diabetic ketoacidosis. When dapagliflozin was launched, you had bladder cancer coming in, and slowly you had a lot of people talking about urosepsis, acute kidney injury, euglycemic diabetic ketoacidosis, Fournier's gangrene, and so on and so forth. And even some people spoke about the change in bone mineral density and some markers of bone mineral density going up. But over a period of time, these 50,000 patients cumulated together in these 8 outcome trials, cardiac, renal, and heart failure, has shown us that the adverse event leading to discontinuation is almost closer to placebo. So you don't have serious adverse events on these drugs, especially except some euglycemic ketosis and genital tract infection, which is going to be common when you have glycosuria. And if you remove a secretagogue or insulin in a patient who goes on a very, very low carb intake, you can have enhanced gluconeogenesis, and the Randall cycle comes in, and you can have increased non-esterified fatty acid delivery to the liver, and your ketone bodies could go up. So that is the only condition where, or the only situation, clinical situation, where SGLT2s should not be given. So any infection or patient in hospital, SGLT2 inhibitors are better to be withdrawn. EMPA-REG outcome study came exactly 5 years back at the EASD. It was a fairy tale kind of a study, which with empagliflozin showing excellent benefit in patients with established cardiovascular disease. Now, we all know what happened in the 3-point MACE and heart failure reduction and cardiovascular death, but the secondary endpoints in terms of renal outcomes, which was incident or worsening nephropathy or progression to macroalbuminuria or a composite renal endpoint, you had a significant close to 46 to 40% reduction in all three, which was a secondary endpoint in terms of its EMPA-REG outcome study. Again, what it showed is that patients who were patients with type 2 diabetes and high CV risk, empagliflozin given in addition to standard of care reduced HF or cardiovascular death with a benefit observed in those with and without heart failure at baseline. So if I can just take you back to the EMPA-REG outcome study, you had 10% patients with heart failure. So this observation of a reduction in hospitalization of heart failure or cardiovascular death was seen in patients with and without heart failure. And it's very important to note that in patients with type 2 diabetes, majority of the patients who go into heart failure are patients with preserved ejection fraction. So a sub-analysis of the CHARM study with candesartan in 2016 had shown that adverse cardiovascular events are much higher in patients with diabetes with preserved ejection fraction as compared to patients with diabetes and reduced ejection fraction. So adverse cardiovascular events include a softer endpoint like hospitalization due to heart failure, could also include a harder endpoint like sudden cardiac death or cardiovascular death. Now, again, this was a very good post-hoc analysis which was presented at the virtual ADA this particular year, and this looked at how early after treatment initiation are the CV benefits of EMPA apparent. As you know, in the EMPA-REG outcome study, the benefits in the Kaplan-Meier curve actually came out within a few weeks of treatment itself. That's why everybody thought that probably it's too early or too premature or probably shocking to believe that a drug could have that kind of benefit. So this post-hoc analysis was presented at the ADA this year and showed that CV benefits with an early separation of the curves occur, and they explored at what time after randomization do the benefits become apparent. So it also looked at the benefit of empagliflozin in reducing the risk of HHF, then a composite of CV death and HHF, and obviously CV death emerged within a few weeks. Now, if you look at this particular post-hoc analysis, which was submitted and published, presented as an abstract and an oral presentation, this post-hoc analysis of the EMPA-REG, it showed a reduction in risk with empagliflozin versus placebo with HHF on the 17th day itself. So if you look towards the left hand of your slide, the hazard ratio goes below 1 on the 17th day. So by the 17th day of introduction of a new drug to standard of care, you had a softer endpoint in terms of a hospitalization of heart failure going down. Now, if you look at a combination of cardiovascular death and HHF, it seems to be around 27th day. But if you look at a harder endpoint, now there cannot be a more harder endpoint than mortality. And that's what separates the EMPA-REG from all other study, because there's no other study which has shown a 35% reduction, 38% reduction in cardiovascular death. And this apparently becomes significant on the day 59. So by the end of the second month of therapy, you have reduction in cardiovascular death. And that is significant in terms of practice itself. Now, now a lot of people globally actually criticize randomized control trial and cardiovascular outcome trial, and also criticize that the patients are very high risk and event driven trials. When you have high risk patients, you're bound to get a lot of events, and probably what you get may not be actually seen or replicated or cannot be extrapolated to a garden variety of patients whom we see in our clinics. So here you have the EMPRISE study, which looked at almost 40,000 patients. This was also presented as an abstract at the virtual ADA this year. And this looked at 40,000 patients, where almost 140 covariables were matched. So again, you have a 140 propensity score matching, because many a time when you have a real world evidence, you are actually comparing apples to oranges. 140, usually you have around 35 to 40 variable matching, but 140 covariables matching is very, very rarely seen in real world evidence. And here you see that early findings from EMPRISE, which was presented, is that empagliflozin is associated with decreased risk of hospitalization for heart failure, a similar risk for MI and stroke in routine clinical care. So in a subset of population with complete mortality information, empagliflozin associated with a decreased risk of all-cause mortality compared with DPP-4 inhibitors. So in the EMPRISE study, you are actually comparing an SGLT2 empagliflozin to the usage of DPP4 inhibitors in almost 40,000 patients. If you look at cardiovascular outcome trial, and we have now, as I can say, that we have actually got a lot of got more insight into these drugs and more information about how to treat patients, and we have newer and newer outcome trials coming in, with the ertugliflozin Vertis CV being the last cardiovascular outcome trial on SGLT2, which came in 4 months back. Now, if you ask me how it works, we still don't know whether the mechanistic studies have shown that probably it's osmotic diuresis. There's a hemodynamic regulation. There is uricosuriya. It causes beneficial effects on the lipids. There's reduction in oxidative stress. It reduces arterial stiffness. The ketone hypothesis of a change in fuel mediated hypothesis, a reduction in sympathetic nervous system, diuretic causing a reduction in visceral adiposity. We still don't know. But overall, it seems to be that SGLT2 inhibitors have robust evidence in reduction in hospitalization for heart failure, and also robust evidence in prevention of progression of chronic kidney disease. And SGLT2, like empagliflozin, has an indication for reduction of cardiovascular death, which is one of the hardest endpoint one can see in a clinical outcome trial. So that's why the guidelines have changed. The guidelines have changed that in drug-naive patients who have ASCVD risk, you start with an SGLT2 or a GLP-1 RA. The ACC again changed it 2019 that patients who have risk of cardiovascular disease and are drug-naive could be directly put on to an SGLT2 inhibitor also. Thank you so much. That was my last slide, and it would be wonderful to hear Dr. Punjabi speak about similar kind of things from a cardiology perspective. Thank you, Lupin, for giving me this opportunity. Over to you, Dr. Punjabi. Thank you so much for the patient hearing.
Rajiv, will you unshare your this?
Yes, I'm doing that. Sir. Yeah, I've done that.
Dr. Rajiv has made my job very, very simple. He has very clearly shown what a wonder drug of this decade that we are talking about, SGLT2 inhibitors in general, empagliflozin in particular. Congestive heart failure, as we all know, is a huge problem all over the world, more so in our country, where we have millions of people suffering from congestive heart failure and millions adding every year to this list. Now, diabetic patients have been studied for a long period of time and have been found that they have a much higher risk ratio as far as cardiovascular disease is concerned, coronary artery disease is concerned, peripheral artery disease is concerned, or stroke is concerned. Of these all, heart failure seems to be the most important or the most highest affected presentation in these patients of diabetes. The incidence may range from 6 times higher incidence to 8 times higher incidence in diabetics of prolonged period of time. Various heart failure outcome studies have shown again that various diabetic outcome studies have shown that heart failure is a more common outcome than MI, strokes, or death in case of diabetics trials that have been studied over a period of last several decades. Now again, there has been a debate as to whether we need a more intensive control of diabetes, whether that makes a difference as far as MI, strokes is concerned, or whether we need a lesser control of diabetes where it is favoring heart failure patients, where you require a less tighter control as the mortality morbidity increases rather than decreases. So as Dr. Rajiv also pointed out, the various studies, various drugs have shown that the hazard ratio does alter from drug to drug as far as heart failure is concerned, favoring metoprolol, metformin initially, then the insulin, and now of late the GLP-1 antagonist and the SGLT2 inhibitors. The Empareg outcome trial, as he pointed out, showed a dramatic reduction in the incidence of heart failure, and it was driven mainly by the heart failure, though the other factors were also affected, the mortality, the all-cause mortality, all of them were influenced by the SGLT2 inhibitors, empagliflozin. Now, he also showed us various mechanisms by which the pathophysiology and management of heart failure is in action. As far as this drug is concerned, it causes natriuresis, just like a diuretic. It has a protective effect on the kidney, and therefore the cardiorenal physiology is preserved. It reduces the preload, afterload by its vascular benefit on the endothelium as well as the wall stress. It reduces the interstitial edema. These are possibly some of the mechanisms by which SGLT2 inhibitors work in heart failure. As we study this molecule more and more, we realize that there are more and more plethoric, pleomorphic ways by which it works rather than just by reducing the blood sugar levels. By anti-diabetic action, it is relatively a very mild drug, but when combined with metformin or combined with other oral anti-diabetics, it is very effective. What is more effective is more than reducing the blood sugars, it does reduce all the pathophysiologies which we see in cardiovascular cases. In heart failure, we are aiming at preventing heart failure by proper control of blood pressure, use of statin, preventing coronary artery disease, episodes of ischemia, use of antiplatelets, etc. When we are treating heart failure, we have some of the very, very novel drugs, ARNI, ivabradine, MR antagonists. We have devices like CRT and ICD, which are helping on improving the life quality as well as improving the mortality, morbidity in patients of heart failure or ischemic heart disease. Where both the things are concerned, preventive as well as therapeutic is concerned, ACE inhibitors, ARBs, beta blockers have found to be definitely very useful and very helpful. Moving on further, Empareg outcome trial showed us tremendous benefit as far as all the effects on the heart and the blood vessels is concerned, as well as on the kidneys is concerned. And this stimulated a design for studying them in more details in special group of patients, especially with heart failure, with a reduced ejection fraction. By we mean Emperor reduced trial, where an EF of less than 40% was screened, and these, in addition to raised BNP, were already on all the standard medical therapy, whether it is ACE inhibitors, ARBs, or RNAs, or beta blockers, or MR antagonists, along with ivabradine, diuretic, all the appropriate devices wherever necessary as per the guidelines. Another study, Emperor Preserved, was also designed, where again the EF more than 40% was screened, and they had one additional parameters of a structural heart disease in the form of a left atrial enlargement and or left ventricular hypertrophy documented on echocardiography. They were admitted for heart failure in the 12 months prior to the screening. They also had raised NT-proBNP. With all these criteria, they were divided into two trials, Emperor Preserved and Emperor Reduced, a study on 20 countries, including Asian countries, including India. These studies had a very, very remarkable results that we shall study. What was the three endpoints that were tested in this study? The primary endpoint was composite of cardiovascular death or heart failure. The first secondary endpoint was heart failure, total heart failure, first or recurrent heart failure, hospitalization. And the second secondary endpoint was the slope of decline in glomerular filtration rate over a period of time. With this goal in mind, to study patients of reduced ejection fraction, especially in the Emperor reduced trial, the design was to randomize patient 1:1 either to empagliflozin 10 milligram dose or a matching placebo, and all the patients were receiving appropriate heart failure therapy prior to being enrolled in this study. 7,000 odd patients were screened, out of which 3,730 were selected. The duration of study was 16 months, mean age was 67, and the percentage of female in this group was 24%. All were above the age of 18 years, chronic heart failure with NYHA function in class 2, 3, or 4. LVEF, as we said, was less than 40% or equal to 40%. Heart failure hospitalization within 12 months were also available as history. Their NT-proBNP was raised. They were or without atrial fibrillation. When they were present with atrial fibrillation, double this value of NT-proBNP was taken as a criteria to include them. Exclusion criteria were the acute coronary syndrome, the strokes, the TIAs, heart transplants or recent surgeries, valvular disease, acute decompensated heart failure, or any procedure in the form of ICD or CRT in the previous 3 months. These patients were excluded. 70% of them were white patients, 18% were Asians as well. Various countries were from where they were recruited. 75% of them were in NYHA functional class 2. The mean LVF was 27%, 50% of them were diabetic, 50% were non-diabetic. eGFR was less than 60% in 48% of the patients. So we had a sick group of patients with heart and with kidney disease or early kidney involvement. And all of them were medically optimally treated. Almost 70% of them were on ACE and ARBs. Almost 10% of them were on ARNI. Almost 94% of them were on beta blockers. 71% were already on MR antagonists. ICD was present in almost 31%, CRT was 12%. So from this salient features itself, you realize how sick was the group of patients, and having chosen such patients with all the appropriate guidelines directed therapy, they were put on additional empagliflozin to see the effect of empagliflozin and to realize that the primary outcome of cardiac death and heart failure in empagliflozin group was 19.4 as against 20.7 in the placebo group, with a hazard ratio of 0.75%. Cardiovascular death was 10 versus 10.8. Heart failure hospitalization was 13.2 in the EMPA group versus 18.3 in the placebo group. So this slide summarizes the benefit of empagliflozin was noted in this study. A remarkable 25% reduction in primary endpoint of cardiovascular death and heart failure, which was statistically very significant. First secondary endpoint of total heart failure hospitalization of nearly 30%. As we know, heart failure hospitalization is a very, very costly affair for these patients, and they tend to get admitted repeatedly. And it is not only the cost factor, but every time they get admitted with heart failure worsening, there is a worsening of the myocardial status, there's a worsening of the ejection fraction, leading to sudden cardiac death as well as low cardiac output death. Secondary endpoint were also surprisingly very, very prominently showed a reduction of nearly 50% in renal events, which was decline in the glomerular filtration rate. A real bonus benefit was noted in addition to the cardiovascular benefit that we saw with empagliflozin. So empagliflozin prevented heart failure and serious kidney failure as well. And both these factors are very, very prominent, very, very surprising, very, very promising. A 50% reduction in the renal hard endpoints and a 25% reduction in heart failure, hospitalization, and cardiovascular death. So with these two, it is becoming a compelling indication to use SGLT2 inhibitors in addition to the currently recommended treatment for heart failure. As we all know, heart failure management requires beta blockers. Heart failure management requires ACE inhibitors or ARBs or ARNI, one of the three. Heart failure, wherever possible, requires MR antagonists. Heart failure, wherever indicated, requires ICDs as well as CRTs. And with all these things in the background, still heart failure is a malignant condition which has its 50% mortality in 5 years period of time. So when you have a disease which has 50% mortality in 5 years duration, you need not to use just one drug or one device, but you need to use whatever is available at your disposal to arrest the disease, slow the disease, and improve the mortality, and improve the clinical outcome as well as the quality of life. Now, with this significant improvement between the empagliflozin and the placebo, as far as serious side effects are concerned, were very, very negligible compared to placebo, whether it was the cardiac patients or whether it was the renal patients. Among the lesser side effects, adverse effects of interest, volume depletion was hardly a matter of concern. Hypotension was hardly different from the placebos. Symptomatic hypotension was no different between EMPA and the placebo. Hypoglycemia episodes, surprisingly, were also not very prominent. Ketoacidosis was a possibility, but not a significant, statistically significant condition. Urinary tract infection tended to be higher in cases of empagliflozin, but still again not statistically significantly different from the placebos. Genital infections were 3 times higher. These were the only major side effects that was noted, especially patients with on empagliflozin compared to placebo. But we have to realize that these were manageable. These were in the subset of major group of diabetic patients already prolonged period of time of diabetes. The other much feared side effects which are earlier feared about the SGLT2 inhibitors, bone fractures, amputations also were not at all different, making them relatively very safe drugs to use. So total hospitalization was statistically different. Clinical composite renal endpoint as per the need for chronic dialysis, renal transplant, sustained reduction in the eGFR, fall in the eGFR, all-cause mortality, new onset of diabetes, significant reduction in HbA1c, reduction in systolic blood pressure and diastolic blood pressure without any major hypoglycemic events. All these were stars or feathers in the cap of SGLT2 inhibitors. So beyond doubt, SGLT2 inhibitors, whether it is empagliflozin, dapagliflozin, or the other gliflozins which are not available in India, they will become a standard therapy. I need not go into the mechanism of actions by which they help, but just to summarize, they reduce the cardiac preload, they shift to ketone metabolism, they have an adaptive cellular reprogramming, they inhibit the sodium hydrogen exchange in the cardiac tissues, they improve the endothelial function, they reduce the cardiac fibrosis. These are the novel mechanisms by which SGLT2 inhibitors show their effect. Insulin-dependent action, reducing independent action of reducing the glucose-urea, improved hypoglycemic control by the persistent glucose-urea, sustained lowering of HbA1c, durable significant weight loss is a very, very important mechanism by which it benefits the heart and the diabetes. Low risk of hypoglycemia is unique feature about it. Reduce mild osmotic diuresis, improved blood pressure, compatible with all the other diabetic therapies, improved blood pressure control. All of these factors and many other unknown to us are the means by which this drug works. And no wonder new 2019 ESI guidelines recommend the treatment as a class 1A. It's a first line treatment for diabetes and heart failure, including metformin, SGLT2 inhibitors, as against the other drugs which are so far available. I think that is all that I have to add, and we shall be glad to take questions if there are any. Dr. Roshan, yeah.
Yeah, thank you, Dr. Ashok, Dr. Rajiv, for your presentation. The thing is, there is a question for Dr. Ashok. Can empagliflozin can be used for multiple severe risk factors from the audience?
Yes, it can be used, and that is what has been very, very clearly pointed out in the EMPA-REG patients as well as in the EMPEROR-Reduce outcome trials, that in patients with multiple cardiovascular risk factors, even before they develop heart failure, you can still use them, and they would have definitely a good benefit as far as long-term results are concerned.
Yeah, that's right. Dr. Rajiv, there is a question that's, can empagliflozin can be treated as par with metformin if we initiate early?
Pretty a funny question, I would say. Empagliflozin as first line therapy. I think the question is that whether we could use EMPA as a first line therapy. Yes, the ESC has surely come out with guidelines that you can use empagliflozin or other SGLT2 inhibitors also as first line therapy in patients who have established cardiovascular disease. Now, patients without established cardiovascular disease and multiple risk factors, also there's an indication that you can use them in patients with very high risk for cardiovascular disease. Apart from that, you feel that the patient deserves the benefit of an SGLT2 inhibitor, you can use that. So even in a country like the US, where everything is evidence based, only 80% of the patients who are newly diagnosed actually start off on metformin, and a lot of 20% of patients are started on other drugs. So metformin, because it being easily available, cheaper, and adverse reactions being almost close to placebo, it becomes the usual drug of choice to be started in patients without established cardiovascular disease. So if I have a patient with established cardiovascular disease, I would also think of starting the patient on empagliflozin in a drug-naive patient.
Okay. Okay, there is no more question. So my thing is for the audience, sir, Dr. Ashok, what are the precautions to be taken when using the empagliflozin for the patient? In cardiologist perspective, actually.
Initially, when we started using, as Dr. Rajiv pointed out, we were definitely scared because all the side effects which were possible with this SGLT2 inhibitors were so much highlighted and so much pointed out as the fear of ketoacidosis, fear of amputation, fear of infection and sepsis, urosepsis and all that. But having used the drug for diabetes initially and then for the heart failure patients, we realized that the incidence of side effects are very, very few. The need to discontinue the drug because the side effects are extremely rare, and therefore they can be used quite safely without fear, without phobia, with precautions. And especially in our elderly patients, where we deal with very frail patients, severe heart failure, the age group is very high, more than 70, 75-year-old patients already on a lot of diuretic therapy. We need to be a little more cautious, make sure that they are not in the dehydration state, make sure that they are not having any significant infection to begin with, urinary infection especially. Apart from that, there is little to fear about using it even in the sick patients.
Thank you. Dr. Rajiv, dermatologist perspective, what precautions can be taken when using SGLT2 inhibitor?
So one, don't use it in patients with type 1 diabetes. We have seen some patients being put on SGLT2 inhibitors. Do not use it as a weight loss drug, which a lot of people have been using. It's not scheduled for use in children and not scheduled for use in patients with pregnancy and diabetes. We should not use it below an EGFR of 30. We don't know after DAPA CKD it comes to 25 or not, but an EGFR 30 is a cutoff point. Do not use it in patients who are at very high risk for ketosis, which means patients who are LADA, patients who are on do not remove a secretagogue or an insulin directly from a patient and introduce and replace with an SGLT2. Again, patients in hospital, whether they are in hospital for an infection, infarction, or surgery, it's preferable not to use this molecule. So these are the various don'ts for an SGLT2 as a blanket, not specifically for EMPA, I would say.
Thank you. So there is no more questions. So we're concluding the session, sir.
Thank you.
Dr. Ashok, Dr. Rajiv, thank you for your wonderful presentation and sharing your valuable experiences. And on behalf of Lupin, thank you very much. And
Thank you so much. Thank you, Dr. Chaudhary. Thank you, Dr. Punjabi. Thank you very much.
Thank you, Dr. Rajiv. Nice
Thank you,
meeting
sir.
you.
Same here. Bye-bye.